Welcome to the New Mom Talk podcast, your go-to podcast for evidence-based answers to your burning questions about parenting. Join us as we dive into commonly Googled topics and hear from experts and real moms. Let's navigate parenthood together, one question at a time. Hi, everyone. Today we're going to talk about ACOG guidelines on breech presentations and vaginal deliveries. So I am really excited about this because I feel like we often hear about moms talking about their babies being breech and they're going to have to go in and have a scheduled C-section, or their birth plan is essentially not going to go to plan because their baby is breech. That said, we have Dr. Elliot Berlin with us that's going to talk to us about this topic. So if you could start off with telling us a little bit about yourself and what you do.
Well, thank you, Mariella. Thank you for having me and for really broaching breech. It's a really important topic. I'm a pregnancy-focused chiropractor, so I went to school for both massage therapy and chiropractic and smushed them together to make what I feel like is the peanut butter and chocolate of holistic healthcare. We have a musculoskeletal system that is deeply intertwined, so I like to address it from both the muscular and skeletal components. And my clients, for the most part, are pregnant or postpartum. That makes up about 80% of the clientele that I see. Working with that population has really put me in a situation where I get a lot of questions all the time about things that I didn't necessarily know answers to as a chiropractor or as a dude. And I did a lot of research. And as I was getting the same questions again and again and answering them again and again, I started to try to compile them in ways that would be meaningful. And that kind of led to the creation of Informed Pregnancy Media with a couple of podcasts, a streaming platform, and a whole bunch of documentaries, including one called Heads Up, The Disappearing Art of Vaginal Breech Delivery, which I think really talks to the topic that you have here today, or what are the facts?
I love that you mentioned chiropractic care because I'm currently 37 weeks pregnant, and this pregnancy I've been seeing my chiropractor. Feel like it's made a world of difference.
Amazing. I'm glad we have your back.
No pun intended.
Slightly. I am a dad.
Let's start off with talking a little bit about what ACOG stands for and why this is important for expecting families to know.
Okay, so ACOG, they kind of come together, that four-letter acronym, people call it ACOG. It's the American College of Obstetricians and Gynecologists. And it's the leading authority on U.S. maternity care guidelines. Primarily what their mission and focus is on protecting obstetric providers, medical doctors, and then secondarily protecting women and babies. So the only reason I say it that way is because they're not always the same. For example, when something will increase liability, which is risk to your doctor, it doesn't necessarily increase medical risk to you or your baby. But in that case, ACOG's main allegiance is to protecting the doctor, not necessarily to protecting the mother and the baby. Of course, whenever possible, they try to do both.
Wow, I just learned something. I did not know that. Well, that said, what do the current, I'll go ahead and say ACOG guidelines say about vaginal breech birth, and how have they evolved over time? As I mentioned earlier, I think this is a very common topic where you hear moms say, oh, because my baby's breech, I'm going to have a cesarean.
Yeah, so I would say the current guidelines are the 2023 update on breech from ACOG. But I think if we go back to the 2001 update, you can see a picture unfold. So I think a very legitimate question was being asked in the 70s, 80s, and 90s, which is, once cesarean birth became a lot safer and more predictable, who would be better off having one than having a vaginal birth? A very legitimate question with new technology. Early on, cesarean wasn't safe. We only did a C-section if the mother and baby were both in deep risk and we could try to save one of them. Could we cut her open and get the baby out safely? And yeah, I mean, really even earlier on, if you go back much earlier to maybe where the name Caesar came from, there was a law, case cesarea, where if a pregnant woman were to pass away, they would take the baby out and not expect the baby to be alive, but bury them separately. That was the law. I think it had to do with strength in numbers. So when you have more numbers in your citizenry, even if they're deceased, it's stronger for the country. So they would bury them separately. And then they found out if we cut her open, we might find that the baby's actually still alive in there. And that was sort of the early roots of the idea that we can potentially get a baby out safely that way, or at least alive. Anyway, over the years, cesarean became a lot safer, more predictable. The techniques and what we understand about germ theory and spread and how to do incisions and how to heal wounds and stitching, antiseptics, all of it just became much safer. And it's a very simple surgery nowadays to do safely. So as that happened, we started to wonder, well, if the baby's sitting, let's say the placenta is sitting right on top of the cervix, placenta previa, and the baby has to smash through that placenta to come out vaginally, which is pretty risky, would they be better off just having a cesarean birth? And pretty much everyone agrees, yes, they would. And so we started to apply that question to more things. And then in the 90s, we applied it to breech babies. When you deliver a breech baby vaginally, there are a couple of things that can go wrong, that complications that don't happen with head-down babies and that don't happen with a C-section. And the thought was, well, what if we just get them out by cesarean and avoid the potential for those complications happening? And a trial was set up at McGill University in Canada by Dr. Mary Hanna and colleagues. And they essentially took 2,000 women who had breech babies and assigned 1,000 of them. They said, you're going to deliver with their permission. So you're going to deliver vaginally, and the other 1,000 you're going to deliver by cesarean, and we'll see how the outcomes are for the babies in particular, and to some degree for the moms as well. And their findings were a small but statistically significant better outcome for the babies immediately after birth when they were born by cesarean versus vaginally. And based on that one study, really without giving me a lot of time to explore the results of that study, after it was published in 2001, the United States and Canada, here in the US, ACOG, came up with guidelines that all breech babies, the recommendation, not a law, that all breech babies should be born by planned cesarean. And when that happened, the option for breech birth almost disappeared overnight. When ACOG makes a guideline like that, again, they're protecting you from liability, and doctors don't want to do things that are risky for them. And so they stopped, they just said, oh, you have a breech baby, you must have a C-section, and we recommend doing it at 39 weeks. Once that happened, there was no more training. You can't learn how to deliver breech babies, which is a different skill set, if nobody's delivering breech babies. Now, flash forward 2 years, they did a follow-up study on those 2-year-olds that were born in the original study, and they found no long-term difference in health based on mode of delivery. So the vaginal babies and the cesarean babies, neither group really had any difference in long-term health. 2 years after that, researchers who had been kind of exploring how this study was done in the first place came out with a whole bunch of criticisms of the study. And one of them, Dr. Glazerman, made a recommendation that the findings of the term breech trial should be rescinded completely because of some of the issues in how the study was performed. And it was then that ACOG changed the guidelines to say, you know what, it's possible that vaginal breech delivery is a good option for some people, not everyone. And the real limiting factor at that point was finding anybody who still had the skills or confidence to do it. And that hasn't really changed. So the 2023 outcomes, the guidelines from ACOG, are that vaginal delivery could be a good recommendation for you if certain criteria are met. The position of the baby makes a big difference. They need to be butt down, essentially, not like a foot down. The baby's head is flexed, the chin to the chest, because when they're extended back, it's a bit riskier. They recommend only doing it if the baby is between 2,500 and 4,000 grams, which is about 5.5 to almost 9 pounds. And that if you have an experienced team, so providers who have experience with breech birth and all the maneuvers and equipment that go along with that, and an experienced emergency cesarean option if that is necessary. So those are the current guidelines.
So it almost sounds like it's something that a lot of doctors don't really want to do. However, moms or parents can choose to potentially advocate for this if they are a candidate. So that said, what would be like the criteria that a doctor might consider when determining if somebody is a good candidate for a vaginal breech birth? I know you kind of described the positioning of the baby. So if a mom is like, no, I really want to try a vaginal birth, I want to try to advocate for this, how can we determine if I am a good candidate?
That's a great question. So one thing that the study didn't look at all is what if you've already had a vaginal birth? So That's important because the two main concerns we have when you deliver a breech baby vaginally are, number one, head entrapment, which means the whole baby comes out, but the head gets stuck. So if your baby's head down to begin with, and you start delivering a head down baby that is not breech, if the baby doesn't descend or come out, nothing comes out, and you can just do a cesarean, right? But if the whole baby starts to come out and then the head gets stuck, that can create a serious complication where, the lungs are activated, the baby's trying to start breathing, but they're in a semi-aqueous and inaccessible to us position. That could be a real serious emergency. And the other one is umbilical cord prolapse. So when the head is down, snugly up against the cervix from the inside, from the womb, nothing can really come through until the head comes through. But let's say there's nothing down there, or just a foot down by the cervix. What could happen is the umbilical cord can sneak through first and move through the cervix from the womb to the birth canal. That can become a dangerous complication also, because the next thing that comes through is the baby. And the baby can compress their own cord, their own source of everything that they need for survival. So when you already have, and I don't like any of the obstetric terms, the traditional obstetric terms, but the one for if you've given birth vaginally and there were no complications, they call it a proven pelvis. If you already have a proven pelvis, the odds of a baby getting stuck, even a breech baby getting stuck, go down dramatically. But that's something that the original study, the term breech trial, never looked at. Meaning if that was the only change in the entire study, and you only looked at women who already had a proven pelvis, and now they have a breech baby, and you put half of them to deliver by cesarean, half vaginally, I think you'd find very, very different outcomes. In fact, it might be statistically significant better outcomes for the ones delivering vaginally than the ones delivering by cesarean. And it might even be greater than just statistically significant. I can't promise that or prove it because I haven't done the study. Nobody has. But there's a very good likelihood that that one criteria by itself would change everything in the opposite direction. Other things are, so now that you understand the risks that we're trying to avoid, the reason why a butt down baby, so either like a frank breech, which means the head's up, the butt is down, and then the feet are kind of up by the head like they're doing a pike dive. That is going to be generally blocking the umbilical cord from coming through. The butt sitting right there by the cervix will block the umbilical cord from coming through and having that prolapse issue, just like a head down baby would have the head blocking. But they wouldn't want to do it if it's just a footling breech, or certainly not if it's transverse, if the baby's lying sideways and nothing is down there, or any of those positions would be more concerning. So that's why the position matters. We're concerned about babies getting stuck, so that's why they put the weight guidelines on there, 500 to 4,000 grams, or 5.5 to almost 9 pounds. They won't want to do it if the baby's over 9 pounds because of fears of getting stuck. And there's also the head position. If the chin is tucked to the chest, they generally come out without complication. If the head is extended back, then they're more likely to get stuck on the way out and have injuries. And so those are some of the criteria that they look at. Also, amniotic fluid. They like to see good amniotic fluid. If the fluid's too low, that can also maybe set you up for a cord issue.
When you say 9 pounds, that sounds like a big baby to me.
It sounds like a big baby to me too. And I would just say that, one of the things that outside of breech that has happened in obstetrics is called pelvimetry. It's the measure of the pelvis, the mom's pelvis, and sometimes the measure of the pelvis in relation to the measure of the baby's head. And what they were looking for is what they call cephalopelvic disproportion, where the baby's head, cephalon, is too big to come through the mother's pelvis. And very early on, the way they would do that is just with calipers. They would try to push back the soft tissue and measure the bony outlet of her pelvis, and then sort of make a decision, do we think this baby's head can get through there or not? Then they were doing x-rays. Everybody got a crotch shot x-ray before the baby would come, a few days before birth. And we could see clear pictures of the baby's head and her pelvic bones until we realized that's a big cancer risk. So we stopped doing that. And then they were doing CTs, which is even more radiation. So CAT scan is really just a whole bunch of x-rays together to try to create a 3D image. And then ultrasounds, which are sort of grainy and not great pictures, but less risky. At the end of the day, the recommendation seems to be to not even measure, because the only way you'll know is if you try. And that is because, in my opinion, none of those pictures take into account function. They only look at structure. And both the pelvis, the mom's pelvis, and the baby's head have function built into them. The head is designed to mold and move through a smaller space than is full circumference. And the pelvis is designed to be able to expand and contract and accommodate the baby's movements and transmit something bigger through it than its static measurement. And so if you look at if you have good function of the baby's head and you have good function of the mom's pelvis, then a much larger head can come through a much smaller pelvis. And this really became clear to me when I was doing doula work, and I was at a birth where a patient of mine gave birth to an 11-pound baby vaginally, unmedicated, and are you sitting down? She didn't even tear. It was a pretty darn smooth birth. And part of that was because she got herself into a very oxytocin state, and she did it deliberately with methods that she learned from reading Ina May Gaskin's books on birth. But she got herself into a very, very oxytocin-rich state. And we talk about it on our podcast, the Informed Pregnancy Podcast. It's an episode called Labor Day Surprise. And I'm like, you got to come on and talk about what that was like for you, because it was the most incredible thing to see. And again, it's 11-pound baby. So you're saying 9 pounds sounds like a big baby, and it does to me too. But I think by no means does that mean it can't come through smoothly if there's good function.
Hi everyone, it's your host Mariella. I wanted to thank you for listening and share some ways to show your continued support. You can rate and review on Apple Podcasts or Spotify. Share the show with friends and family. Buy me a coffee to help with the financial costs of running a podcast. Follow me on Instagram at newmomtalk.podcast. And finally, subscribe to my newsletter. Thank you for listening. So given that, I know you mentioned that the criteria was updated in 2023, I believe. How accessible would you say that a vaginal breech birth is today for those parents that really are wanting to advocate for trying a vaginal birth?
Well, it depends where you live. Fortunately, in most of the world, it's not very accessible. In the United States, I think maybe less than 5% of breech babies are born vaginally or even attempted a vaginal birth. And here in Los Angeles, where I am, we used to have a few doctors that were skilled and open to doing selection, looking for, are you a good candidate for this? And if you are, putting that option on the table if it's something that was interesting to you. But they are rapidly, they're the older doctors, and they're rapidly either retiring or, stopping to practice or stopping to deliver altogether, or towards the end of their careers. We have one who did so many, but now he doesn't want to do them anymore. He's like, I'm at the end of my career, and liability again is a concern for him. It's not because he feels that they're risky to the mother or the baby. It's just risky to him because it's not the community norm anymore. Some hospitals won't do it, won't allow it for liability purposes. Some insurance companies seem to not allow it, not allow their doctors to do it. Or if they do, they have to buy a separate rider for it. And then just some doctors just don't want to do it, or now more than ever, don't really feel confident doing it. They don't have the training. And so they don't really know how to do it. And so you're left with a very small number of facilities and practitioners who do it. In California, we also had midwives who were doing it, but maybe 10 years ago or so, a little more, California changed the scope of practice and took breech out of the scope of practice of midwifery. So they're no longer allowed to do it. So you have doctors who could do it, but either don't know how or don't want to. And you have midwives who did feel comfortable and never lost the training, but no longer able to do it. So the answer to your question in short is through most of the United States, there's very little choice. I see people travel really far to have a vaginal breech birth sometimes.
Wow. So then what risks and benefits should families weigh in if they're able to find somebody that would be open to trying a vaginal birth in their situation? What are the benefits and the risks to weigh and to take into consideration if it's really worth trying or if it's worth just going the C-section route?
Yeah, that's a good question. And ultimately, at the end of the day, that's what I think your whole program is about, your whole platform is about, and mine too. I'm not advocating for people to do something or the other thing. I'm advocating for people to have the information and be able to make an informed choice and to be able to be supported in that choice. So I think just as much of an advocate for someone to have an elective cesarean, even though there's no medical need for it, as they are to have a vaginal birth with a breech baby or a vaginal birth after cesarean, which seem to be harder and harder to access. And so that's everything we do is a risk-benefit analysis. When I get into the car to go to the market to buy milk and eggs. I'm thinking, well, getting into that car has some risks. Driving has some risks, and not all of them are even in my hands. Even if I was the safest driver on the planet, the people around me might not be. And so, do I want to take that risk or not? And why? Because I need milk and eggs to make my yummy breakfast, which is important to me. So I'm going to take that risk to get my milk and eggs. With medical things, we do a risk benefit analysis all the time. And there are always going to be some pros and some cons to all the choices in front of you. And you can only make a truly informed choice if you have all of that data available to you. But to call something safe or risky, I think is a judgment call that only the person who's going to do it can make. So, let's say there's a risk of 1% chance of something bad happening. If you take choice A, well, what's the benefit of taking that choice? Maybe the benefit is having a vaginal birth, and that could be important to you for a lot of different reasons, or maybe it's not that important to you. And maybe a 1% risk of that thing happening sounds like a risk you do want to take, and maybe it sounds like a risk you don't want to take. But you can't necessarily call it risky or safe. There's always risk and there's always benefit. And only you could decide which risk you want to take for what benefit. You could determine if it's going to be risky or safe for you from a medical perspective. And for doctors, they have the same calculation for liability. There's going to be, two choices on the table. They could just attend your birth only as a cesarean, or they can give you the option for a vaginal birth, but that might carry risk for them that they don't want to take. And so what you're asking now is what are the pros and cons, I think, the risks and benefits of that vaginal breech birth versus doing a cesarean breech birth. There's a whole bunch. I mean, one of the factors that I think is two really that are rarely talked about are you planning to have more children or not? So the mode of delivery now, if you are planning to have more children, will affect your subsequent birth or births. If you have a cesarean birth this time, then next time you really only have two choices. You can have a vaginal birth after cesarean or another cesarean, a repeat cesarean, both which are not as safe as having a vaginal birth after a vaginal birth. And so I think oftentimes we don't talk about that. The down the road, we're just looking at this microcosm of what's happening right now. What are the pros and cons in this moment of making this decision? And also, if you're going to have subsequent children, there are some risks and complications that are more common after having had surgery on the uterus, like placenta accreta, where the placenta attaches to the wall of the uterus, not favorably. So it can become a really risky situation during the pregnancy or at the birth. So those are some of the things to think about. There's the immediate healing after vaginal birth gone well is better generally than the immediate healing of a cesarean birth gone well. Long term, there might be some benefits to having done the cesarean. Maybe there's a smaller rate of trauma to the urogenital system with a cesarean birth than with a vaginal birth. With a cesarean birth, you are going to have more control over those two complications that we're worried about, head entrapment and umbilical cord prolapse. You'll be able to eliminate them, but then you open yourself up to the complications that can happen from surgery, infection, blood loss, things like that. So those are really some of the things to consider if you even have the choice.
Yeah, very good point. That said, how can parents really educate themselves and prepare mentally or emotionally for the possibility of a breech presentation, especially later in their pregnancy?
Well, I think listening to your podcast is a great way to start. Getting information. I generally encourage, if you care about the mode of delivery, I generally encourage people to check on the position at 32 weeks. And that's because around 28 weeks into a first pregnancy, about 50% of babies are not head down yet. But by around 32 weeks, nearly 90% of babies are head down. Really, up until that time, there's a lot of room in the womb and they're just moving all over the place. Once they have to pick a position, once they run out of space, which appears to happen between 28 and 32 weeks for many babies, I would say most babies, they have to pick a position and it's generally head down. So if yours is still breech at 32 weeks, it's good to know. It's not a panicky time, but it's a time where you can start to do things and think about these choices and options that may or may not be before you. Then at birth, we go from about 10% at 32 weeks. At birth, it's only 3 or 4%. So a lot of those babies, most of those babies, or more than half, will turn from 32 weeks till the end, but just under half won't. And then you're going to have to think about, are there things that you want to do to try to encourage your baby to turn? And there are options naturally that you could start already at 32 weeks. Chiropractic is potentially one of them, making more functional space for the baby. Acupuncture has methods or positional things like spinning babies. There's a lot to consider that you might be able to do to naturally help the baby find a better position. And it's a good time to look at, well, let's say I get to 37 weeks and my baby is still breech. What are the options then? There's a medical procedure, the external cephalic version, where doctors can try to physically move the baby at 37 or 39 weeks. And then if the baby's still breech, after all of that, what choices do I have and which one would I want to make if I had the option? Do I just have a scheduled cesarean at 39 weeks? Would I rather wait till 40 weeks? Would I rather go into labor naturally and then have a C-section? Would I rather find a provider who offers me the option for vaginal breech delivery? And am I even a good candidate for that? Those are the kind of things I think having that information will make it a lot smoother and more empowering as you get to the final stages of the pregnancy.
Yeah, very, very good points, especially because nothing ever goes as planned. So it's better to kind of think about that as you get closer to delivery. Well, finally, my last question. Do you have any other tips, suggestions, or recommendations for any parents out there that are currently have a breech baby and just need maybe a little bit of advice or some support?
Yeah, 1974, long before the term breech trial, I was born breech vaginally. In fact, I don't even think they realized I was breech until I was making my exit. Um, and interestingly enough, a bunch of the medical doctors that I know who are involved with breech care, who are trying to advocate for not losing the art of breech delivery, we're also three of them were also born breech. And I have no idea if that somehow influences the work we do or not. But I think that if you have a breech baby, we are lucky to have many different ways to get the baby out relatively safely. And if the actual mode of delivery is important to you, then it's important to learn about the things you can do to try to help your baby get into the ideal position, and important to learn what the options will be if the baby remains breech. When it comes to learning more about vaginal breech delivery, I'll reference our film again, Heads Up, The Disappearing Art of Vaginal Breech Delivery. Deliberately made it short, just 34 minutes long, so you can get a lot of information in a short period of time, because the people who are looking for that film don't have a lot of time on their hands, generally speaking. And you can find it at headsupfilm.com.
Well, thank you so much. I appreciate you coming on and sharing all your knowledge. I will have all of your information linked in the show notes for anyone that wants to reach out to you or learn more about your podcast from there. So, yeah, thank you.
My pleasure. Thank you for having me. Thank you for the great work that you're doing here. And I'm wishing you the most blessed birth experience in the next few weeks, it sounds like. And maybe you'll join me on my podcast to share what that was like for you.
Thank you. Thank you for listening. Tune in next week for our next episode. You can find us on Instagram for more updates and tips. Be sure to subscribe wherever you listen to your podcasts and give us a review if you like us.